So welcome to this EDTNA ERCA webinar. So our presenter today is Professor Anne Bonner, and many of you who are joining us today will know Anne and will have met her at many of the conferences that we have joined up at across Europe and across the world in over a number of years. So Anne is head of the School of Nursing and Midwifery at Griffith, and she's also a visiting research fellow at Kidney Health Service, Metro North Hospital and Health Service, and there she leads the Renal Nursing Professorial Unit. She's a visiting scholar at Princess Alexandra and Logan Hospitals and chief investigator in the NHMRC Chronic Kidney Disease Centre of Research Excellence. She's attracted over $6.5 million in research funding, which is an amazing amount, and she's got over 30 years experience in nephrology. Her research interests are around symptom management, self-management, health literacy, and advanced practice nursing roles. Anne's got over 150 publications and has delivered over 200 peer-reviewed conference presentations. So she's a dab hand at this, and we're absolutely delighted to have Anne here with us today, an expert renal nurse. Anne, welcome. Over to you.
Thank you very much, Helen, and it's a delight to be able to talk to you from Brisbane, Australia, where it is just after 10 o'clock at night. On a very balmy evening. I'm going to make you all very jealous and tell you at the moment it is 24 degrees Celsius. I have a fan blowing on me because it is quite warm, and you're in the depths of winter. We don't get winter in Brisbane, by the way. So, as Helen's introduced me, I'm going to be talking about health literacy and what it really all means, and what it particularly means for adherence for the people that we care for. So I'll just clarify today what health literacy is and is not. Then I'll look at some of the evidence around health literacy in chronic kidney disease and how we might assess for health literacy. And then I want to talk about some strategies, and I'll focus on one in particular that's really important for us to consider using as renal clinicians to actually bridge that gap between what patients actually do understand and we assume that they do understand. In other words, we assume that they might understand more than they really do. So why is adherence a challenge for people with chronic kidney disease? And I use the term chronic kidney disease here to mean every stage, whether on dialysis or on conservative treatment or haven't had a transplant. Well, adherence really isn't the patient's problem. It's actually our problem, because we largely believe that if we give people some knowledge about their treatment and what to do, that they actually will go away and do it. And the mere fact is us explaining to people once or many, many times about particular treatments, you know, whether it's taking your phosphate binders or sticking to your fluids or turning up for dialysis or whatever it might mean, means that they're actually going to do exactly what we tell them to do. And that's the issue, is that we're often sitting there, and although we don't do it, we're almost pointing our finger and wagging it at people saying, this is what you're supposed to do. But just giving information presupposes that people have actually understood everything about their health problem. And that's not necessarily the case. And I'm just going to challenge you in a little while about some of that thinking. So, in other words, there's a gap, what we call the health literacy gap, between individual skills and abilities that people have and the complex demands of health and the healthcare system. I mean, we've all been exposed to working in, you know, hospitals, small and large, and when you've gone from one hospital to another, You sort of get a feel for what hospitals are like. If you go into a hospital in one country, there's many similarities to hospitals in other countries. Of course, there are differences, but, we go into hospitals all the time as part of our professional lives. But everyday people don't, and so they find the healthcare system a real challenge to understand and to navigate around. So health literacy itself is quite old. It's not something that's been thought of by a few people in the last few years. It's been around since the 1970s, and back then it was thought of as just people being able to read and to count. So reading and numeracy abilities, and if you could read, everybody presumed that you could understand. And this thinking still sits by and large every single day with all sorts of clinicians. I'm working on a project with a nephrologist around consenting for kidney biopsy. And the terminology, the words that were put for patients was medical jargon that the ordinary everyday person would not understand. So when I was trying to explain what health literacy is, the nephrologist was saying, well, surely the patients can read, therefore they would understand the words. And we know that they don't. So health literacy really is an ability to access, process, and understand health-related information as well as services so that you can make a good health decision. But what is not health literacy? Well, it's not just having functional skills, and functional skills are about reading and counting, such as reading a brochure about chronic kidney disease and the various treatment options. Health literacy is not about just being shown a DVD or a YouTube or some sort of video material. It's not about getting lots of information on the website, because that is just saying that people only understand because they can read or watch things, okay? So here's a little cartoon from The Simpsons. It's a bit blurry, but don't worry about that. And we've all seen the screeds of information that come with medications. Even the very simplified forms for patients is complex to understand, let alone if you read to a high level the language that it's printed in. So if French or German, if you're in France or Germany, is not your first language, but it might be your second or third language, you will struggle to read that. And we all have very multicultural societies as well. So health literacy is not just functional skills. So here is where I'm going to challenge you. Let us assume that your mother has been diagnosed with chronic kidney disease. She's 78 years old. She also has hypertension and type 2 diabetes and osteoarthritis. So she goes to see the renal team, and she gets told that the treatment options are peritoneal dialysis, hemodialysis, or supportive and conservative care. So she comes home and tells you, you're a renal nurse or a renal allied health professional. And she asks you, well, what sort of things should I think about with these three different treatment options? What are the benefits or the disadvantages of having peritoneal dialysis or hemodialysis or supportive care? Well, of course, all of us will be able to answer those questions quite confidently and explain to our mother the differences between the treatment options, and maybe even help guide her with her decision making. And that's what we do, but we know all about those treatments. So here is where I'm going to challenge you. Let's assume your mother, who's 78-year-old with osteoarthritis, and she also has bowel cancer, and she also has chronic lymphocytic leukemia, CLL, that's turned into or transformed into lymphoma. She goes along to the hematology clinic and sees the hematology team, and she tells you that the treatment options are ABVD, PVAG, or supportive care. So she comes home and she says to you, the renal clinician, what is these treatment options? What do all of these A and B and P and V mean? What does that all mean? Which option has the better benefits for me? Which ones should I avoid? What are the side effects? What can you tell me about these treatments? How are you going to help me to tell which option should I have? So, you're all health literate in the renal world. You understood peritoneal dialysis, hemodialysis, supportive care. You could explain that. You could give, simple explanations. You could take the time. You might even go into work and come home with some equipment to explain it to your mother. But what would you do if she's been to see the hematology team and she comes back with 3 different options? How is your health literacy? What do you know? How can you assess it and understand it to help make a decision? And this is really tough to do. And I gave this presentation similar to this one I'm doing today at the Home Therapies Conference last year in Australia. And it was a very mixed room with, nephrologists and nurses and allied health professionals. And not one person in the room could tell me the difference between ABVD and PVAG. So I said, well, your health literacy is challenged or it's lower when it's taken out of the context that you're familiar with, where you've got lots of knowledge and experience in. And by the way, this was my mother, and the option that she ended up having was PVAG, which is 4 different types of chemotherapy drugs. So it was a real person. So why am I giving you that example of your mother getting the renal diagnoses and treatments or the hematology one? Well, it's to illustrate that health literacy is not just about focusing on knowledge, if you like, or functional skills, and that it's static. It's actually contextual. It changes. So when you're in one environment, say the renal environment, you yourself have a lot of health literacy abilities. Take you out of that environment and put you into a different context, different, say, specialty that many of us don't know much about, our health literacy is much, much lower, even though we would probably say to everybody else, oh, we have good health literacy, but we probably don't when the context changes. So what I'm going to do is show you a brief video, and it's only 30 seconds, so I'll stop talking now so that you can see the video.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through 1 a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
What was that all about?
Jamaican chicken recipes.
Made some decisions about it, and then they know what to do or how to do something. So clearly that poor lady has been given an inhaler, had a very quick explanation, but she hasn't really understood it because of the way a clinician gave her that information, and therefore her ability to adhere to taking her inhaler properly is flawed. It's problematic. In other words, the patient has tried to be adherent, but, you know, clearly putting the puffer on your neck like a perfume is not going to do any good. But as a clinician, we may have made the assumption for many weeks or months that a patient understood the information and knew exactly what to do, and when we sent them home, they were doing it exactly as we asked them to do. So I'll come back to that example in a little while. So the World Health Organization has defined health literacy over 20 years ago as a cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. So, why is it that, you know, we who spend a lot of time teaching our patients about their renal problems, their disease, their treatment, how to do their dialysis at home, or how to monitor things at home, we struggle with thinking that our patients don't adhere, don't comply to what we've been telling them. And it's because it's our problem. We haven't thought about health literacy effectively. So there are these three dimensions to health literacy. Functional, which is the ability to read and understand the information that you take in, be able to count. Another dimension is communicative, which means being able to communicate in a two-way manner that's equal and respectful with, say, healthcare professionals. And then critical health literacy is about being able to take the knowledge and that communication, think about it all together, assess it, make some decisions about it, and then put into action. So to illustrate, there's been some surveys of the Australian population, and 60% of Australians between the ages of 15 and 74 do not have the health literacy skills needed to understand everyday health information to effectively access and use health services. So if you look at the pie graph over here on the right-hand side, 60% of Australians had basic health literacy, 35% had adequate health literacy, and only 5% were proficient. Now, while this survey has been done, more than 10 years ago, our repeat survey has been done, but they measured it slightly different, but it found similar sorts of things. Again, though, the Australian government only assessed functional health literacy. They didn't assess those other dimensions of communicative and critical. So it's really important because health literacy affects our patients' abilities to use digital platforms to manage their health, communicate with their healthcare providers, review the internet about the sorts of information that's on there, and we know the varying information that's there. It might affect their ability to access appropriate health insurance or maybe government support. So why it's important clinically is to assess health literacy because it helps healthcare systems to manage health. It might mitigate the costs of unnecessary treatment and diagnoses. And if you assess health literacy in our patients, it does, there is evidence to show that it decreases 30-day readmissions. And this article by Parnell in Nursing Forum a year or so ago is a really interesting article, and that's where this information has come from. So health literacy is an essential element in empowering, engaging and activating a person in a person-centred model of care. So across Australia, all hospitals are accredited by the Australian Commission on Safety and Quality in Healthcare, and there are 10 standards. And one of our standards, Standard 2, specifically speaks to health literacy. So hospitals are now being accredited using these new standards, and hospitals have to demonstrate how they're health literate organisations, so that they're supporting staff with policies and procedures and training to be able to understand truly what health literacy is, so that they can support patients in a more effective way. And in the New South Wales state, there is a health literacy framework, and many other states have that. So I was looking around to see what's available in Europe. And Rodiger in Archives of Public Health in 2017 published a really wonderful article where they've cited some information saying that nearly half of all Europeans have inadequate or problematic health literacy skills. And across Europe, they did a health literacy survey, and 12% of all respondents have inadequate health literacy, and 35% have problematic health literacy. And what the authors of this article say is that having limited or low health literacy in Europe is not just a problem of minority population, it's across all populations, and it's a public health challenge that cannot be neglected. And this is the publication. It's Nothing About Me Without Me, and why an EU health literacy strategy is important. So there are some resources available, such as the Health Literacy Centre in Europe, and in there is information and connections to different countries across Europe. And the World Health Organisation has a European roadmap for the implementation of health literacy initiatives. And as you can see, it is not all focused on the individual. It includes society, professionals, organisations, as well, as commercial and government. So it's an across-the-board thing to think about is health literacy. So health literacy depends only partly on the individual person. It is also about health organisations and healthcare providers. And it's us that have to adapt to understanding about health literacy, because if we understand that better ourselves as clinicians and our organisations are adjusted to that, we'll then be able to support all of our patients in a much more effective way. So looking more specifically in chronic kidney disease, health literacy is important because it's part of delivering patient or person-centred care, and it's because people with chronic kidney disease spend most of their time, like 98% of their time, away from the hospital and need to be able to effectively manage their own health care. And it really is essential for us because we have these relationships with our patients, and we develop those relationships over a long period of time, and they come to trust us a lot. So even though this was conducted in 2014, in the UK, for example, only 50% of the general public actually knew that kidneys made urine. And 68% thought that too much alcohol damages the kidneys. So really not understanding what the kidneys actually do. So only about a third knew the kidneys removed excess fluid in the body. Only about 25% knew the kidneys balanced chemicals in the body. And only 1 in 10 people knew that the kidneys had a role in blood pressure control. So if the general public don't understand about chronic kidney disease, how is it that when a person has chronic kidney disease, you know, they need to have a lot more knowledge than the general public, and so it's up to us to help them. But we know from the literature, there's a whole lot of literature here, that greater than 70% of people who have kidney disease, chronic kidney disease, have poor knowledge of their condition. They don't know what the kidneys do, why kidney function deteriorates. They don't know what treatment is needed to prevent dialysis, the options available, or how to follow their treatment plans. And it's very common for people to say that they're shocked by getting a diagnosis of chronic kidney disease. And so by and large, they're unaware of where to find information or how to judge its veracity, how truthful and accurate it is. So even under the care of nephrologists, a study by Gray et al. Have shown that knowledge of CKD is limited. And what Gray did was they assessed patients' CKD knowledge. They've been going to see a nephrologist in an outpatient's clinic in a major hospital. They assessed their knowledge of CKD, and then 12 months later assessed it again, and it didn't improve. So what do we know in around the evidence of health literacy and patient outcomes in chronic kidney disease? Published in Nephrology, Dialysis and Transplantation, NDT, a systematic review by Taylor and this group of authors looked at all of the research around health literacy and patient outcomes. And what they found was, up until that point, there'd been 29 studies. But all of the studies that they included in their systematic review measured only functional literacy. And this is really problematic because these authors clearly didn't understand that health literacy is not just functional. If they'd actually used the correct definition of health literacy, they wouldn't have found 29 studies. They would have found none. Okay. So low health literacy, measured only by functional measures, was associated with greater hospitalisation and more cardiovascular events in non-dialysis CKD patients. And low functional health literacy was also associated with reduced dialysis adherence, hospitalisation and mortality. So you could imagine if you'd actually included studies that had assessed all 3 dimensions, these results, if there had been studies up until this point, would have shown perhaps worse hospitalisation, worse cardiovascular events, even less adherence and so forth. So this systematic review is very flawed. But they didn't find any evidence for a causal effect of health literacy on patient outcomes, and they said more research is needed. Well, first of all, more research is needed to actually assess health literacy correctly. So in this article, Schruben looked at, and this is quite recent, looked at the relationship between knowledge of CKD and health literacy and the uptake of self-care behaviours. And what they found was some evidence, but not a lot of strong evidence. There's also a systematic review by Katrina Campbell and others in the Cochrane Library looking at interventions for improving health literacy in CKD. And at the moment, the protocol is still sitting there. I've seen a pre-published version. Again, they've not really thought about health literacy across all dimensions, and there isn't a lot of evidence about interventions to improve health literacy at the moment in people with chronic kidney disease. So a lot of people try to assess health literacy using the rapid estimate of adult literacy in medicine, the REALM, or the test of functional health literacy in adults called the TOFLA, or newest vital signs. But all of these three and others only assess functional health literacy. And being able to read is not a measure of comprehension, nor is it the ability to evaluate information. So using these ways to assess health literacy is very flawed, because it's only looking at functional, and it's only in certain languages and things like that. And if you're illiterate or you have very low schooling levels or low reading abilities, it doesn't mean that you can't understand. If you get information given to you in different formats, and we've all done this as clinicians, shared it in picture form, simple short verbal explanations, people do understand and take in some information. But can they process it, communicate it, and ask questions with the healthcare provider, or critically think about it to be able to make some choices, make some decisions about their health? I'm not sure they can. So another assessment is the Functional, Communicative and Critical Health Literacy tool. That's been used in a few studies in renal patients, and here's a study that was actually conducted in Australia looking at treatment adherence, and they didn't found too much associations between treatment adherence, partly because this instrument has not been it's not valid and reliable really to use in this in our patient population. So the main way to assess health literacy, and there's many versions of what's called the Health Literacy Questionnaire. It's been recommended by the WHO, and it assesses 9 different health literacy domains, and it assesses a person's abilities to understand, engage with, and use health information and health services, and it also assesses the organisational or the hospital capabilities to provide services that support a person to understand, engage and use their health information. And it's all from the perspective of the patient. So it was initially developed in Australia, and it is recommended by the WHO. It's freely available. You can use it as clinicians, and you can also, if you fill in a form, use it for research. And it's a PROM. It's a patient-reported outcome measure. And they've done some studies in various countries testing the different language versions. So Une Elizabeth Stromer has actually used the Health Literacy Questionnaire to measure health literacy in patients with chronic kidney disease in Norway. And this was published a year or so ago in Nursing Open. And she's also published in the Journal of Renal Care, the EDTNA, ERCA journal, Health Literacy and its associations with quality of life and adherence. Now, this is an excellent study, and she's divided it into two parts, and I'm going to show some results in a minute. But it's very worth going and having a read of both of these articles, because you're getting a sense of what health literacy is all about in people with chronic kidney disease in Europe, and what the health literacy questionnaire shows. So the health literacy questionnaire has been used in a couple of studies to measure in measuring health literacy in people with varying levels of chronic kidney disease. So Stroma has done that in Norway, Dodson in Australia. I've done other studies both in Australia and also in Vietnam, and I haven't got my results there, but and also there's been a recent publication in Canada. And these are the 9 domains along the left-hand side here that show the different health literacy areas that are assessed, from feeling understood and supported by the healthcare provider and having sufficient information, people's confidence or ability to appraise health information, navigate the healthcare system, and then, find good health information and understand health information well enough to know what to do. So these first 5 domains are ranked, the person filling the questionnaire in rank it between 1 and 4. And a score over 3 shows quite adequate health literacy. Scores around 2.5 or less show low health literacy. And in these domains, also ranked, but there's different number of questions that are answered. So a score of 1 is the lowest and 5 is the highest. Again, they try to use a bit of a cut point of around 3. Is anything lower than 3 is low health literacy. So when you look at these different studies, one in Europe, one in Australia, and one in Canada, that measured all 3 domains, functional, communicative, and critical, using, a robust, validated, and highly recommended by the WHO assessment tool, you can see that there are similarities in these, if you like, Western and each of the 3 studies was domain number 5, appraising health information. And that's being able to process it, think about it, and then know what to do with that information. Okay? So appraisal. And if any of you teach, appraisal is a much higher order skill than being able to define or explain or describe. So that's just health literacy. But surely there must be a link between knowledge about chronic kidney disease, a person's health literacy, and self-management. And all 3 together are crucial. So if you've got good knowledge and strong health literacy abilities, surely then your ability to self-manage and adhere to treatment is likely to improve. So I've been thinking about this for a lot, for a number of years, and I now have a PhD student who's actually taking this thinking on as her PhD study. And we've just had accepted for publication in the Journal of Renal Care a scoping review where we investigate the recent evidence of health literacy and the relationship between health literacy, CKD knowledge, and CKD self-management. So we included studies involving adults with any grade of CKD, as long as they measured all the dimensions of health literacy and not just those functional ones like that systematic review published in NDT. They measured CKD knowledge or CKD self-management, or both of those at the same time. And there were studies that were published in English around the world between 2005 and 2020. So we've found 11 studies, but none of the studies have actually reported all three. Some have reported health literacy and CKD knowledge, and some have reported health literacy and CKD self-management. So none have actually looked at the relationship between health literacy, the knowledge levels that people have about chronic kidney disease, and how well do they self-manage their CKD. So this is what Jennifer's PhD will be about, and she's actually started recruiting participants already. So the study that I mentioned before that was published in Kidney International Reports only measured functional health literacy. Again, just that narrow understanding of what is health literacy. So what can we do about it? Well, perhaps there's, some reasonable things that are quite common sense around health literacy. And so there are 5 steps to better health literacy. Number 1, speak slowly. 2, we could use teach back. We could encourage questions, use plain, very simple language, and show examples. Well, I think we all can understand about speaking slowly, questions and plain language and showing examples. But the one I'm going to focus on now is what is teach back. And to me, this is a useful strategy. So teach back has been around for, about 15 years. And it's also known as show me or closing the loop. And it's an active process of increasing patient engagement and confidence in understanding things. And it's asking patients to repeat in their own words what they need to know or do. And it's in a non-shaming way. So we're not trying to test a patient, okay? We're not giving information to a patient and saying, well, I'm just going to test you on what you understand. It's not that at all. What we should be using it is as a check for understanding, and then, if necessary, reteach the information. We may reteach it in the same way. We may modify the way that we teach it. And those of us who teach in our professional roles, in other words, we're trained educators, and we teach in primary school, in secondary school, in universities. This is exactly the sorts of strategies that we use all the time to facilitate learning. But again, when we're clinicians, most clinicians are not trained to be educators. They might not have completed a formal qualification in education of others, whether children or adults. So it's these additional skills that we need in our clinical practice. So that's why teach back is quite useful, because it's quite a simple thing to do. So this is what I mean by it's a closing the loop concept. So we're giving information to a patient. We might explain it or demonstrate it. We then ask the patient to explain it or teach it back to us or to show it back to us. We then can clarify and tailor our explanation to the patient. Then we can reassess their ability and they might, the patient might understand it or be able to show it quite well, demonstrate mastery, and that hopefully will lead to greater adherence or reduced amount of errors. And Teachback, this cyclical approach, was first published in 2003. So the key elements for using Teachback is no closed questions. And what do I mean by a closed question? You give a patient information and then say, do you understand? And a patient will say, pretty much most of the time, yes, I understand. Another closed question is, do you have any questions? And most people are afraid and say, no, I don't have any questions. So the other thing not to do is to teach too much. Always teach a couple of main points and then check for understanding using Teachback. Follow that cycle around. And if their understanding or their ability to demonstrate the 2 or 3 main points is fine, then you move on, okay? So you shouldn't make the patient feel like that you're giving them a test. It is not a quiz. It's not saying, can you answer this question? You know, it's just saying, we've sat here and I've explained all about phosphate binders to you. Can you just explain it back to me, what you understand of what we've just been talking about, and let the person use their own words back to you. And it very much aligns with adult learning principles, where we're encouraging people to be independent, we're drawing on their own abilities, we're trying to stay focused all the time with how we're teaching. It's of relevance to a person, it's applied, so it fits with their everyday life, and therefore it's more likely to become, used all the time. And adults tend to motivate themselves. So using Teachback aligns quite beautifully with adult learning principles. And if we go to the learning pyramid, so sitting here giving you a lecture, maybe only about 5% of what I'm teaching you is going in. But if we move along the learning pyramid, demonstration or discussion, once you get down to the lower end, such as practice doing something or teaching other people, that's where Teachback fits into those last two. So that's more likely to result in greater understanding and being then able to do something because they can do it themselves, practice, they can show you what to do, and they're teaching it back to you, so they're teaching another person. So, is there any evidence about the effectiveness of Teachback? Well, unsurprisingly, because I'm interested in health literacy, I did a systematic review with another PhD student of mine, and we looked at the effectiveness of Teachback on adherence and self-management in people with a whole range of chronic diseases, and we've published this in the JBI systematic reviews. So we found 10 studies at the time of doing this systematic review using Teachback. 4 of the studies were in heart failure, a couple were in COPD or asthma, and some in diabetes. Linking back to the video that I showed you from House, if only that lady had actually demonstrated back to House, to the doctor, how to use the puffer, she wouldn't have been spraying it on her neck, would she? And that's why Teachback is probably a useful thing to use all the time whenever we're teaching our patients. So in the systematic review, we found that the person doing the Teachback were mostly nurses, some were community nurses, but others, pharmacists, physicians and dietitians have also used TeachBack. It can be used anywhere, whether in the hospital, in the community, or on home visits. So we found at the time with those 10 studies that using TeachBack significantly improved outcomes around the knowledge that people had of their disease, their adherence to medication and diet. It built their self-efficacy or their confidence and motivation. What we showed was a positive but inconsistent trend in improved self-care behaviour and reduced readmission rates or to hospitals or hospitalisations. So this was back then when there was only 10 studies that had used TeachBack in some sort of intervention study. So the key elements with TeachBack is that the responsibility is on the clinician, and we should have a caring tone of voice and attitude using plain language. We always ask the patient to explain using their own words and that it's not a test of knowledge. So, because, you know, I'm so interested in health literacy and then TeachBack, another PhD student of mine did a cluster randomised control trial of a bundled phosphate control intervention, which we called the 4Ds, and we did this study in patients with end-stage kidney disease on dialysis. And we've just had published this month in the, sorry for the typo, Journal of Advanced Nursing. Now, what are the 4Ds? And if you look up either Molly, Malazi or Clint or myself, we've also published the study protocol. And we've also published a systematic review on the 4Ds. So the 4Ds is quite obvious. It's diet, drinks, drugs, and dialysis. So all of those are needed all together to help control phosphate. Yep, we all know that. But what happens in clinical practice? Well, somebody talks about diet and drinks, often the nurse and also a dietitian. Who talks about drugs? Well, the nephrologist, the nurse, and the pharmacist. So there's been lots of studies showing that if you give some education about diet and drinks or drugs, you will improve phosphate levels. So in our systematic review, we only found one study that talked about that, one study that did an intervention around the 4Ds. In other words, patients were educated on diet, drinks, drugs, and adherence to their dialysis treatment. When you put all the four together, you should be able to improve phosphate control, surely. That's common sense. But only one study had done it, and it wasn't a randomised controlled trial. So that's why we did this. So we developed up this bundled 4D intervention, and we ran the study as a cluster randomised controlled trial. So what did we find? Well, we measured the patient's knowledge around why phosphate was important for the diet, drinks, drugs, and dialysis. So we measured all four aspects. So at baseline, there was no difference between the intervention and control groups. After the intervention, there was a significantly improved phosphate control knowledge scores in the intervention group compared to the control group. In terms of self-efficacy or people's confidence to manage the 4 Ds. Similarly, there was no difference between the intervention and control group at baseline, but at the end of the intervention, there was a significant improvement in self-efficacy scores. Did they adhere better to their phosphate binders? They did. There was a significant improvement in the intervention group from baseline to the end of the study. There was also significant improvement in adherence to diet, which included fluids, and there was also less missed dialysis, missing any dialysis. So there was more adherence to dialysis. So traditionally, people are given information about phosphate control. But that's assuming that everybody has good health literacy. So we didn't measure health literacy. We worked on the assumption that everybody has inadequate health literacy. It will be to varying degrees. And if we were to do this study again, maybe we would measure health literacy, but it was unnecessary, I believe. But by including teach-back in a staggered way, teaching and using that teach-back cycle process, we actually showed that there was better adherence to treatment. So, teach-back is a simple way to, if you like, think of health literacy around universal precautions. Or, you know, we all know what universal precautions is, or standard precautions about preventing infections. What we should be doing is thinking about health literacy as needing a universal precautions approach. We should be thinking about all of our patients have limited health literacy. None of them have been in nephrology as a professional for a number of years. Go back to my example of going into haematology. All of you would have not known which of those choices to make. So that's putting you as a patient then, isn't it, into an environment that you don't quite understand. So teach-back is a very useful strategy. You could use it on everybody, regardless of the language that they speak, the level that they might read or anything like that. You explain, you assess, you clarify, and you build understanding in patients. So in summary, health literacy has a major role in how well individuals can access their health system and receive quality health care. We should be thinking about health literacy as a universal precautions, and it's up to us to treat all patients as if they have limited health literacy. So looking at this diagram here, health literacy is not just about the person being able to read or to count. It's also what we do as health service providers and the environment in which we work. And it's also health systems and our policy makers, you know, that should be directing us further and thinking more about health literacy. Now, I haven't got the complete answers here because I really don't know how knowledge and health literacy come together with CKD self-management. So watch this space for more answers to that question in the coming years or two when more research is done. So I'll thank you all very much, and I'll Helen will moderate some questions to me.
To you for that really, really interesting presentation. I am sure that I think we've got 70 plus people on here. We'll have really gained so much knowledge and information from that in-depth overview. So thank you very, very much, and thank you for your time, and thank you for doing it so late at night, and I hope you're not too hot. I'm very jealous.
No, I'm not.
Okay, so we're going to ask you a couple of questions. Now, I know that people are asking questions. So you talked about health literacy, CKD knowledge, and CKD self-management. And you explained that we know very little about that and those associations. So I was just wondering, could you tell me a little bit more about that and what the deficit in our knowledge is there and what questions still need to be answered?
Yeah. Well, probably there's numerous questions. I think there, Helen. There's a number of studies that do measure knowledge, CKD knowledge, in a variety of ways. And there's a couple of studies that do measure a CKD self-management. There's now a few patient-reported outcome measures around published. But only a few studies have measured both of those together to try to get associations. But if you don't include health literacy as well, you're only measuring knowledge from the fact of it's a quiz. When you assess a patient's knowledge, it is only what they can recall at the moment when they fill in that particular survey or questionnaire. And it all also depends on, well, the language that it was written in. Is it written at, a certain level? Is it in the person's first language and things like that? So that's why, I do think health literacy needs to come in there. It's a bit of a chicken and the egg. Do I have the health literacy abilities to gain the knowledge to then self-manage? Or do I get the knowledge, okay, and because I've got health literacy abilities that are more than just functional, they're communicative, I can talk with my healthcare provider, I then can critically appraise and use that information to make a decision to do the self-management stuff. Take the phosphate binders, stick to the diet and fluids and things like that. So it's those sorts of questions that I believe need to be answered, is those relationships. And they really haven't done that in other chronic diseases as well. So could you do that in a randomised controlled trial? You probably could, but you'd have to come up with a very interesting intervention to be able to do that. So there are other ways to do that, such as using structural equation modelling and those sorts of things to look at causal relationships between all of these three.
Okay.
Yeah.
Thank you, Anne. That's great, really detailed answer. There are some comments coming in. Thank you for the fantastic presentation. Someone has said, I like the approach that it's our responsibility as healthcare practitioners to be able to give the right information in a customised way, which is fair enough. And she's asked if in Australia, does the nurse education include some specific course or training on health literacy?
No, it doesn't. It actually doesn't. And, it does need to consider that. Absolutely. Certainly, I think it should be incorporated into postgraduate study, so specialisation study. While ideally it sounds useful to have in the bachelor degree, ours is a 3-year bachelor degree and it's jam-packed. In fact, I'm reviewing our a curriculum for accreditation, and that's what I've spent most of today doing. And there isn't a great deal of space for it. I think it's a really good question, though. I'd like to definitely put it into postgraduate coursework study. Yeah.
Okay.
And somebody's asked for my email, so I'll just put my email in again. I'll put it into the chat, but it's also on the slides, which I know everybody will get as well.
Yes. Okay. Somebody else Sabine has asked, do you think it's necessary to agree to a goal with the patient? I think we have to pick them up at a point where they want to learn more about a specific topic, and that this could be written into the care plan to guarantee continuity. You can see that, can you?
Yeah. Look, I do think goal setting is useful, but I also think that sometimes patients, or sometimes us, have unrealistic goal setting. We've got to think of goal setting as incremental, very small. For example, let's assume that the patient still smokes cigarettes, okay? So rather than having a goal of stopping smoking, maybe the goal is to smoke 2 cigarettes less each day.
Mm-hmm.
And then when they come back, yes, I've been able to make that little goal, and maybe the next goal is to reduce it by another 2 cigarettes each day, that sort of thing. Or,
yes.
If you're weight loss or trying to do exercise, it's their small, realistic and achievable goals around goal setting, I think.
Okay.
But the goal setting needs to be linked with what you're trying to teach the person. And
yes.
I think the first principle is always to get them to teach it back to you.
Yes.
And what we do, when we teach our students at university, is that we break them up into small groups, give them something to do, whether it's a problem-solving exercise or some other sort of activity. They talk to each other, they're teaching each other, and then they often feed back to the bigger group. They're teaching it back, aren't they?
Mm-hmm.
That's teach back, isn't it?
Yeah,
It's a very simple way. Yeah, we do it. It's bread and butter for us because we're in an education environment. But when you're a clinician, you're often, highly skilled and knowledgeable, but you're put into these roles to be an educator. And have you got, a qualification in education? Probably not. Yeah.
Okay. And we've had a comment from Helder. She's said that she's done a study on health literacy in promotion of self-management, and she found out there's an association between the two in Kenya, and that you're right.
Yes.
Be good to hear more about that, Helder. Yeah.
Yes.
The other thing is somebody asked, can the health literacy questionnaire be used in the general population?
Oh, yes, it always is.
Yeah, always is. Yeah. Good. Okay.
Yeah.
Right, keep typing your questions. I'm scanning to see what else is there, but I had another question. So you talked about adult learning, Anne. You talked about having to deal sometimes with people who, because of their past experiences that are ingrained in them, have difficulties with understanding. So, for example, someone might present with very low self-esteem, which has developed in early childhood in the home, and so that's been with them for 30 years. And we then come to teach that person. Any hints or tips for how we get past that? How do we deal with what's ingrained and what you bring to the consultation?
Yeah, that's a great question, and I think in nephrology in the renal area, we're quite fortunate because we see and interact with the same person over a prolonged period, so we can establish that professional relationship and build that rapport and trust over a period of time, and gradually help, if you like, overcome any of those barriers or challenges, whatever the person might come with. Some will be quite complex and challenging, and others may not be. But it's developing that professional relationship is crucial. And I think Teachback does that because you're doing it in a non-judgmental way. And, you know, and you're not saying, you know, I just need to check what you've understood. You can say, look, I know this information and what I've been explaining to you is, you know, is quite new for you. And, you know, one way for me to be able to help you better is to hear what you've learned. So, you know, if you can explain it back to me, then you'll be able to go home and explain it to whoever at home. And so that's the advantage of TeachBack, is that you can use that in your communication, professional relationship building with patients. And look, I'm not saying everything's going to work all of the time and it's going to be easy, but I think it's those skills that we have as clinicians that we can try to bring to the fore. You know, and it is challenging, and we all have bad days. You know, we want to just explain quickly to a person and we've got to move on. But it's really taking a person-centered approach, being with the individual at what the individual needs. And that's a challenging time for us, and it's particularly challenging at the moment given, you know, all the pressures that's on everybody with health services delivery. Yeah, so, you know, I think we try our best all the time. Yeah.
Okay, can you just tell us a little bit more about your PhD student who's doing their study in this area? And you mentioned the systematic review and the justification for the study, which was excellent. Whereabouts is that student at? You said, did you mention that they have recruitment?
Yes.
And what are they going to do?
Well, she's actually from Nepal.
Okay.
And so we have got the Nepali version of the Health Literacy Questionnaire, and that's what I mean. It is actually available in many languages, and to me, Nepali is certainly not in the top 10 of languages spoken around the world.
Yeah. Okay.
And we've translated and validated the CKD knowledge instrument called the KICS, and we have translated and validated the CKD self-management instrument. That's one of mine that I've published on, and we're now recruiting in Nepal, and she's doing it remotely. She lives here in Brisbane, and we're recruiting and collecting data remotely because of COVID. She can't get back to Nepal, and if she could, she can't come into Australia. We've got the barriers up for all international travel, and only letting those nasty tennis players in who are moaning and groaning about being in quarantine for the Australian Open. Don't get me started on Djokovic. So we're actually managing to do the study. She actually started recruitment on the 4th of January, and she's got, as of, she met with me on Tuesday, and she's got 73 already in her study.
Wow.
Yeah.
Great.
So don't let COVID stop you doing things.
No, that is amazing. That's really interesting, actually, because, as you know, we've got a huge COVID problem in the UK, but our students are still able to move. So we have a lot of students from Saudi Arabia, and they are coming and going at the moment. So that's why your COVID numbers are very good then. We're maybe struggling.
Yes, that simple answer is yes. Yeah, you know, there's no flights. Nepal is like India at the moment, with a lot of COVID cases, and it's a very poor country as well. But yeah.
So she has managed that very successfully. So she's got really good links in units, and how is she making that happen? Yeah, just with her links.
Well, no, she's trained a couple of research assistants who are nurses, but not renal nurses, and they're entering into RedCap, the cloud version, so she can see the recruitment and data collection in real time.
Great. Excellent.
Yeah. Mm.
Okay, so any other questions from anybody in the audience? I know there are a lot of you out there and still a lot of people on.
Hafer's talking to me privately.
Oh,
Hafer was my student. She's in Saudi. Yes.
Yes, Hafer. We reference you very regularly in our work in the UK. I've met you, but I know your name.
Helen, I think you did meet her in Krakow. Oh no, you weren't in Krakow.
No,
no, you didn't go to Krakow.
I don't think I just know the name so well because of anyway. Okay, so no, someone's just messaged me to say that they have sent another question, but I can't see it. Oh, there's something in chat now. Someone said thank you. Hanny says thank you. Oh, here it is. So this is Afra from Barcelona. Very interesting topic. She really enjoyed it. She's thanked you very much, and she's part of the scientific program committee as well, and she does feel there's a need to improve education in this area. And she would like to share with everyone that one of the nursing interventions in all areas, not only in CKD, is education, not only to patients, but also to students.
That's right.
We become professors at the university. I really believe that there is a lack in education skills. Are there any education strategies or instruments that us nurses can use? So I suppose that question's really around, general nurses out there. How do we improve their health literacy? And you've talked about some strategies for that, Anne.
You can use. Look, I think the main thing is, we could be using TeachBack all the time. Helen and I were chatting about how we do it in our tutorial groups with our students. The same thing can be done with nurses.
Yeah,
exactly. But just remember, health literacy is always going to change. Go back to that example of being in renal and then in haematology. You are not going to have the same amount of knowledge and understanding and critical skills in everything. None of us can do that. And so you've got to work on thinking about health literacy as needing a universal precautions approach.
Yes.
In other words, treat everybody as having limited health literacy skills. Yeah.
But it's important, isn't it, Dan, that, we are healthcare practitioners early on, but we have to educate. We're not necessarily given those skills in education. Yes, if we want to go and work in the university, we have to do a teaching course or program and get registered. Why do we not need that to teach our patients?
Yeah.
So that we teach well and we understand these ways of teaching that are going to increase health literacy.
And therefore, I think it's important, particularly in chronic disease type areas where the vast amount of what we do is doing some sort of teaching, patient teaching.
Yes.
Even just simple explanations that we do all the time on the run, that's teaching. And so I think it is important that people consider, adding to their repertoire of skills by going and getting a formal qualification in teaching adults.
Yes. Okay. Well, I'm looking at the time now, and you've been talking for a long time, and I do thank you again. And I hope that you can have some chill time before you head off to bed. It's a completely different time for everyone around the world.
Yeah, that's right. That's right. It's nearly 11:30. I'm just going to make you all very jealous. I'm looking at the weather at the moment from right where I am, and I can tell you it's 23 degrees Celsius. It's nearly midnight.
I think it's about 4 here in Ireland.
Well, I've got short sleeves on.
Okay, well, thank you very much, Anne, and all participants, anyone who's still there, hopefully you're still all on.
Yeah, and thank you all very much. Thanks, Karen. Thanks, Hafer. Thanks, Suzanne. Motivational interviewing. Yes, motivational interviewing is a repertoire, but it's not going to change health literacy.
Yeah. Okay. Yeah. And some people saying that they've used the Teach Back method. It's very useful. So it is out there, but it's just spreading the word. Okay.
Yeah.
Great. Yeah. Thank you. So everybody, just thank you so much for joining today. You are what makes these webinars, and we will continue to provide them. We're so sorry that we haven't had the conference in real life. We're all challenged, but it's fantastic to be able to meet online and to be able to keep our education and to bring speakers like Anne in and to have you all engaging with your really interesting questions. So take care, everyone, and we really hope to see you in real life very soon.
I hope so. Thank you all very much. Bye. Bye.
Bye-bye. Bye-bye.